Hello, everyone. Welcome back to Luncheon with the Experts, Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I'm a filmmaker and a writer that has been working with CCF for 10 years. That is 1 decade, if you're keeping count. Working with CCF, creating all sorts of video content. We have an extensive library. Sometimes it's documentaries, patient-centric stories. Sometimes it's treatment-based videos. And sometimes it's live video series like the one that you're going to watch today, all with the same mission in mind, and that is to raise awareness and educate people about neuroendocrine tumors. Now, I want to go ahead and call attention to something that you may or may not be confused about, because just about an hour ago, I gave the little 1 hour, T-minus 1 hour announcement that the show is coming back on with our guest, Dr. Philip Boudreau, which if you're looking at the screen, you might understand that it is not our guest today. So things happen, folks. This is the life, especially of a medical expert. Things happen all the time. We have to be prepared for that. And I believe that Dr. Boudreau was called away on the surgery. Our guest maybe can clarify that, but I'm very, very excited to welcome back to the show Dr. Mary Maluccio, who so graciously filled in the last moment, in the 11th hour, as they say. Thank you so much for filling in. Thank you for being here. And thanks for Dr. Boudreau for trying to be here, and we will have him back, I promise. Dr. Maluccio, how are you?
Oh, I'm doing great. And yeah, it was a last minute clinical thing, and it was just, inflexible. So
it happens. It happens. And so what we try to do, folks, is establish great relationships with our guest experts like we have, so that they come through for us in the clutch when we need them. Dr. Maluccio, I know that you were on the show recently, and probably a lot of our attendees do as well. But for those who may be new to the show or new to this journey, can you tell us a little bit about what you do, the work that you do in the neuroendocrine tumor space?
Oh, sure. So I am a surgical oncologist by training, although my professional niche has really been in cancer programmatic development. And so I was recruited down here probably close to 3 years ago to take over the directorship of the neuroendocrine program in New Orleans. So Phil Boudreau is my partner. And that was at a time when Gene Woltering was slowly transitioning to retirement, having built a phenomenal program in this area, and it serves a good portion of the southern part of the country. So I've been here around 3 years, and as a program developer, I feel like I have some perspective on the value of each component of a program, as opposed to being so heavily rooted in the surgical aspects of it. Although obviously a surgeon by training, I probably have some sort of mentality on where surgery fits. And obviously this program has really made its mark in the surgical world. But so I've been here around 3 years, and it's been a great experience.
Awesome. Well, folks, I see some of you in the comment section already introducing yourself. We love to see how far these programs reach. So go ahead and say hello to the people in the comments. And if you're new to this journey with this disease or new to the show, I want to say welcome. And I highly encourage you to do the same. Tell everybody hello, introduce yourself, where you're from. But more importantly, make that connection, because I think that the show and what the foundation does is really twofold in terms of the value it provides. One, connecting people with information like we do with this show from the experts, but two, creating a community, because I've learned that the shared experiences and stories within the community are often just as helpful. So if you open yourself up to the community, I promise you it will embrace you. This is a very powerful, very strong, and very supportive community. So you should take advantage of that. Before we get started moving forward with the show, we want to thank our sponsor, Ipsen Biopharmaceuticals. Without their support, we wouldn't be able to do Luncheon with the Experts. It's simple as that. But we have this disclaimer from them before we get started, and that is that the opinions expressed by the guest presenters, as well as the questions asked by the audience, that you all at home, haven't been created or suggested by the sponsors of Lunch with the Experts. And CCF doesn't endorse, promote any of the views, opinions, or information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guests, and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Okay, so that last line is really the takeaway there. We're going to give you some good general advice and hopefully answer some of your questions, but by no means do we or our guests know your specific case. So take that advice, take those answers back to your home team, which does, and make the best plan and path moving forward for you. A couple things, more housekeeping bits before we get started, especially because we have a guest that we weren't necessarily expecting, but I know is always in high demand. The numbers are already reflecting that. So if you know someone that should be here, like, oh my gosh, it's Dr. Mary Maluccio, tag them in the comments, let them know that the show is going on. The more people here, the better. You can always replay the video. It will, as soon as we're done, it will be posted and published here on the Facebook page. And starting next week, we will republish it to YouTube so that people that don't have Facebook can watch it. So you're going to be able to get value from watching the replay, even if you don't make it. But really, the interactive aspect of it is so valuable because if you've been struggling with a question in this journey, getting that question across can be really helpful. Now, to that point, we get so many questions every week, we inevitably don't get to them all. So if we don't get to your question, or if you have a follow-up question and it doesn't get touched on today in the show, reach out to CCF and they will get you the information you seek. And my final ask of you is to, if you see in the sidebar a question that you also have the desire or want to learn the answer to, or you have interest in learning more about it, just under the comment, there is the ability to like that question. You can hover over the like button and it gives you a few different emojis to use, but they all work the same way for me. And that effectively upvotes that question. So I see there's a demand for it. Again, if we're getting hundreds of questions in 60 minutes, we're not going to get to them all. But if I see 7 or 8 people have the same question, I know that one is important for me to get across. So let's make sure we do that. So talking with Dr. Maluccio before we started recording, and knowing this from having her on the show before, I think she's kind of open to any question that you may have. So go ahead and start sending in your questions. And Dr. Maluccio, I'm going to go ahead and start taking the questions from the audience, if that's okay with you.
Absolutely.
Great. Okay, so Bernadette says, are typical lung carcinoids less likely to come back? So I guess the question really is about typical versus atypical.
Okay, so that's a great question. So just as she alluded to, there are 2 main categories of bronchopulmonary neuroendocrine tumors. One would be a typical carcinoid versus an atypical. And really, that is in expectations of biologic behavior, the likelihood of lymph node and distant metastases. And so the typicals is they tend to be the slow growing, very indolent biologic behavior. However, on the flip side of that, the more normal the cell types are, actually, the more likely they are to trigger and then spew out stuff that gives people symptoms. And so the typical carcinoids, and I think I answered this in the last time I was on here, is that the initial surgery that someone has that we hope will be the one and done surgery, meaning that you take it out and you never actually have a carcinoid or neuroendocrine specific event over the course of your remaining lifetime, is really just primarily to get a diagnosis to determine whether or not it is typical or atypical and to stage the patient accurately. So if you were to look at that, I don't think there's a whole lot of data on then the risk of multifocality or the risk of additional sites of disease, but a margin negative resection has eliminated that tumor in and of itself, but you have neuroendocrine cells all over your lungs. So whatever the risk was that drove the manifestation of the original tumor are going to exist. It's just such a slow growing process that you may not manifest it over the course of your remaining lifetime. And even with people with multifocality will live a long time. They just may need to have symptoms controlled if truly it's a functioning tumor. So I hope that is an adequate answer for that, because multifocality is a known problem with bronchopulmonary carcinoids, but the surgery is trying to eliminate, to the extent we can, that process over the remaining lifetime.
Got it. Thank you. And thanks for your question. Next question, moving right along from Kathy. It says she's giving a little bit of context about her situation. PNETs with heavy tumor burden in the liver, on 3rd cycle of CAP-10 with no shrinkage to the tumors, and PRRT is not an option, and the liver is 33 centimeters large. Do you have, so the question is, do you have any recommendations for a drug to help shrink tumors?
So I think that's a sort of a complicated problem when you have bulky, so not knowing really much about this case. So just to say, if you have bulky metastatic disease in the liver, the liver is a significant driver of a neuroendocrine specific mortality. So we pay a lot of attention to the liver. It's probably more of a priority than even the primary site in patients with metastatic neuroendocrine tumors. So you're really not necessarily only looking for a drug, because liver-directed therapies, catheter-based liver-directed therapies, have also been used extensively in patients with metastatic neuroendocrine tumors, including PNET. The difference is that depending on where the tumors are, the size of the tumor, and some of the complexities of liver-directed therapies, that may or may not be something that was discussed with her. And for whatever reason, they may have said that it was too risky a proposition. But the liver-directed therapies are associated with a really quite reasonable, if not quite high, short-term response rate, meaning an appreciable shrinkage in the tumor volume, and a quite reasonable, greater than 50% durable response rate, meaning it lasts 6 months or longer, or potentially even years. So when you start talking about drugs, meaning that you're trying to take something for all over body treatment, the actual response rate, shrinkage of tumors so that you get satisfaction that the drug is worth it, is really quite low. And in neuroendocrine, keeping things the same is often the best that we have to offer. So when you are on to what we think is third line, which is not necessarily means that you're getting into weaker and weaker lines, you're just choosing to approach it with a slightly different strategy. I don't necessarily think that response is really what we're looking for, and we're just looking for a delay in tumor progression, but that there will be times where we will then rebiopsy, or we will take additional information about the tumor burden, send it for genetic or genomic testing to determine whether or not it's got some sort of mutational burden, for which we would actually choose a drug that's not necessarily routinely utilized in neuroendocrine, but perhaps in lung cancer, like Keytruda. And we would then have a reason to believe that that would be an effective drug, including effective at shrinking tumors.
Awesome. Thank you. Thank you so much for that. Before we move forward, I just got a great comment from Deborah that says, Dr. Boudreau saved my life. I'm officially NED, no evidence of disease because of him. Please give him my love. We want to keep throwing that love out there. And thanks for filling in for him, Dr. Maluccio. Absolutely. Thank you for being here, Deborah.
In filling in for him today, does that mean I indirectly saved your life too?
Absolutely. That's the way I take it.
I want to make sure I'm getting
Yeah. It's a team effort. Absolutely. Absolutely. Thanks, Deborah. Okay. So question from Tom. Tom is a friend of the foundation, often here, maybe every week. Dr. Maluccio, what are your criteria you use for determining if surgery for repeat small bowel lymph node mets is warranted? And then also, secondary question, what are risks involved for seniors with multiple resections?
Okay. Yeah. Let's start with the first question, because there is no established criteria, which is why I highly recommend second opinions. So different surgeons are going to have different comfort levels with the degree of cytoreduction that is possible. The overreaching question, if you're looking at it in tumor board and just saying, do we even put it on the menu of options, is whether or not you feel that you can cytoreduce down to greater than 70% of the total tumor burden. And that is in all sites, not just the liver, not just the lymph nodes. And the concept of that, even though there's no magic to 69 versus 71, that is that if you can debulk someone down appreciably, then, and they are somatostatin receptor avid, it gives the somatostatin receptor inhibitor therapy, lanreotide or sandostatin, a better opportunity to saturate the remainder of the disease and delay further growth in the existing tumor burden. So criteria number one is whether or not it's possible to get an adequate cytoreduction. And for those programs that are somewhat more heavy-handed in surgery, like ours, but not only ours, I don't want you to think we're the only one, is that we do have then those guidelines of whether or not you will meet that treatment goal. Now, what complicates a little bit of that question is that the complexities of base of the mesentery lymph nodes, retroperitoneal lymph nodes versus the complexities of liver cytoreduction are two very different questions. So the base of the mesentery can be above the comfort level of a lot of surgeons. So I came into this job predominantly as a liver person. So I look at the liver and say, oh, I could totally do that. And then I look at the base of the mesentery and say, oh, that looks like it would be really hard. But the base of the mesentery, when you think about it, is even slow growth over time can be extraordinarily problematic. Mm-hmm. So your ability to try to diminish that risk of growth around those central blood vessels causing other problems is, I think, where our program in the base of the mesentery has probably had the most opinions on, because we usually get sent the people that have had difficulties with slow growth in that particular area. So at least greater than 70%, it was not actually 90% anymore, 70% of the total tumor burden. And then in answering that question, I forgot the second part of the question.
No worries. The second question was like risks involved for seniors with multiple resections.
Oh, so the risk, and I wouldn't necessarily put seniors and multiple resections. I would say anyone with multiple resections. Fair. Is re-exploration. We would love to do a cytoreduction and never have to go back in. That's for sure. And so the risks associated with re-exploration are not neuroendocrine specific, but that they are trying to get back into that abdomen with a lot of scar tissue, then raises the likelihood of injury to even some of the normal things, and getting complications of like intracutaneous fistula, where you get a hole in the intestine and you end up having, enteric contents coming out through a drain or through a wound, or bleeding is significantly higher in re-explorations, or just some of the complications associated with having to get through a lot of scar tissue, knowing that that's all going to scar back down. Okay. In the base of the mesentery, that can be tiger country, as we call it. There's a lot of incredibly important real estate down there from a vascular standpoint that supplies your entire small intestine and your colon, and in some cases your liver. So I think that it takes one, a multidisciplinary effort, two, someone's comfort level with operating in that area, and three, programmatically a kind of an arbitrary line in the sand whereby we say the risks associated with going beyond this line outweigh the potential benefits just based on institutional and neuroendocrine specific outcomes. And those things have been published.
Got it. Thank you so much. And thanks, Tom, for your question. Good to see your name and a little bit of your profile, a little bit of your face. Christy says, newly diagnosed stage 4. Christy, I am not happy about that for you, but I am happy that you showed up here today. And again, I encourage you to reach out and make connections with the community. They will definitely support you on this journey. I had a question about immunotherapy. This is something that comes up often, especially these days. It's kind of a hot topic. That sounds like it's controversial, but people discuss it a lot. So Patty says, what exactly is immunotherapy? And is it something used for treatment for PNETs, or could it be something used for PNETs with heavy metastases to the liver?
Okay. So immune therapy is a sort of a broad umbrella of things where you are either targeting the immune system in hopes of driving it up, so that your natural immune mechanisms that keep a number of things in check over the course of your entire life have every effort to do that. So melanoma, renal cell cancer, there are definitely clear cancer diagnoses where that strategy of upregulating the immune system to get better defense mechanisms has been shown to be effective and is part of some of the treatment strategies. Now, I think the immune therapy that people are hearing about is what we actually call immune modulation therapy. And that is because cancers will use mechanisms by which they will try to evade that natural thing. And so even if you jolt all of your immune cells into becoming a master army, it may not be effective, but that you need to try to target the mechanism by which the cell is evading it. That's the whole PD-1 inhibitors. Those are the ones that people are talking about. Those are the ones that are clearly part of some of the therapies for lung cancer, for example. So when it comes to neuroendocrine, though, is that there is no algorithm whereby we say, boom, we've done this, then we did this, and now we're going to do immune therapy. Instead, just like I answered in the previous question, you need to actually have tissue that would suggest that that is one of the mechanisms by which that cancer is getting around the immune system. So part of some of those genomic testing, whether or not you're talking about Foundation One or Caris testing, or there are many biotech companies that do some of the precision medicine, is really trying to look at the mutational burden that would be appropriate for that therapy, because we don't use it routinely in neuroendocrine. If you do by chance have that mutation and that mutational burden, it makes not only a lot of sense, it almost makes more sense than some of the other things that we're choosing. So programmatically, and I think that the other neuroendocrine specific programs would agree, is that I think that what we're coming to understand is that we shouldn't wait until we've exhausted all the other things before getting that piece of information, even though we totally do it because tumors can mutate over time, but that we should probably get that information a little bit earlier, even if it's not going to change what we do at that treatment juncture, so that we would better understand the applicability of that for future treatment. And then I personally believe that immune therapy is only going to get more diverse, or immune modulation therapy, more diverse. We're going to get a whole lot more information about it, and we are likely going to find different immune modulation targets.
Got it. Thank you for that. And thank you, Patty, for your question. Folks, if you just joined us or joined us a little bit late, this is Luncheon with the Experts at Carcinoid Cancer Foundation program. And we are here with Dr. Mary Maluccio, who is not, in fact, Dr. Philip Boudreau in disguise, although they are colleagues. And we're having some great questions today. Keep them coming. I have a pretty specific question from Bob, who says, is the phase 2 AlphaMedix decision being made today? Could you clarify, first of all, what that is, and then maybe take that if you can?
Okay, yeah, absolutely. So the phase 2 AlphaMedix trial is a PRRT. So for those people that are more or less familiar with PRRT is when we are using a radioisotope and trying to radiate a tumor using a targeted therapy. Mm-hmm. I describe it to patients so they can better understand it. It's like injecting you with a bunch of little cars that have a little nuclear bomb on top of them, like a pizza delivery system. And it drives over your body. It is sucked out of your bloodstream and ultimately binds to the receptor, the same somatostatin receptor we're targeting with other therapies. Mm-hmm. And the radiation particle is internalized, and it pretty much causes DNA damage to the cell. So what I tell people about PRRT is it's about kind of like getting it into the cell, like the cell is a car, and then messing with the mechanisms by which that car can drive. Uh-huh. So the way that we know where that radioisotope is going to go is that the gallium-68 and the copper-64 PET scans use the same exact attack of car. So the analogy I use is it's a car, the little pizza delivery light. It tells you where that treatment is going to go. And those two images, gallium-68 or copper-64, and then when you put on the PRRT, are almost interchangeable. So let's just get into AlphaMedix. AlphaMedix is using Pb-212, so that's radioactive lead. And for a variety of reasons that I'm sure my nuclear medicine colleague would be like, why the heck did she go down the rabbit hole of radioisotope therapy? But for the lay people, including myself and your audience, is that the excitability and the half-life of lead suggests in phase 1, suggests, but is unproven, that it is going to increase the effectiveness of PRRT. So we're taking the lutetium-177 off the top of the car, and we're sticking Pb-212 or lead on top of there, increase the effectiveness of PRRT, and actually decrease toxicity. but I want to be fair to Lutathera, is that this is not a phase 3. A phase 1 trial is only about toxicity. So it clearly passed the phase 1s and is passed the safety protocols. And the phase 2 is about using it in people that are PRRT naive, meaning they have met progression of disease despite adequate doses of somatostatin receptor inhibitor therapy. Then they would be looking at PRRT as one of the options for therapy. And for whatever reason, the group says, yes, that's a very good candidate for PRRT based on the somatostatin receptor avidity on the PET scan. And then they are choosing the lead as opposed to lutetium-177 in hopes of getting more data to support the effectiveness part of that. So for people that don't really understand the expectations of PRRT, it's really not about response. It's about progression-free survival or delaying tumor growth. And so the response rate is only around 14%, meaning appreciable shrinkage of tumor, have tumors disappear, is very low, but that the value, it's still quite valuable because it can delay tumor progression over what is months to years of time. The PB212 is trying to increase that 14% higher. We don't know whether or not it'll meet that, but we think maybe. And that it will decrease some of the toxicity, although I don't want people to think that our current PRRT strategies have a lot of toxicity. So I don't want people saying they gotta stretch it out until lead goes through all these trials, but that's the phase 2 trial is using lead instead of lutetium-177.
Got it. Thank you for that thorough answer. I love the car analogy. That really helps. Anytime you can explain things visually like that, I think it really helps people, especially with something that can be as dense as medical information at times. I had a question from Barbara about Lutathera treatment. So Barbara, we covered a lot of ground there. That's what lutetium-177 is that Dr. Maluccio was referring to with the PRRT. So if that groundwork that we just laid helped answer your question, great. But if you have a follow-up question that's deeper about Lutathera, let me know. If you're still here on the show, please. Next question from Gene. If you have abdominal or peritoneal cavity nets that look like popcorn ceiling, does that preclude you from any net surgery?
So that's another one that's going to be it depends. Mm-hmm. So I don't want anyone to think that surgical cytoreduction is something unique to neuroendocrine. We do it in other subtypes of cancer that are non-neuroendocrine. So the peritoneal involvement of neuroendocrine can be something that is unlikely to cause significant issues because of its slow-growing nature. But on the flip side, when you are in a program like ours, we usually get some of the people where it is clearly not that way. And that the peritoneal component of the disease, if left untreated, becomes that much more complicated and difficult to treat once those complications have occurred. So I would never tell someone that peritoneal involvement precludes surgical cytoreduction. That's just, that would just be an inaccurate statement.
Okay.
That the sort of the type of peritoneal involvement and the issues that it is causing in any particular patient may make the likelihood of reaching the treatment goal, which is to not have that be a problem in the future, a little bit difficult. So that is very much a patient-specific situation, for which I think that just because we tend to be a little bit surgically minded, right. Is that I firmly believe that even if someone is more medically minded, like MD Anderson, mm-hmm. just at least having a surgeon explain to you in some detail why they don't believe that surgical cytoreduction is appropriate in your case.
Right.
And if you don't feel like that's enough information and you want a second opinion, that's what the virtual platform is beautiful for, because different programs have a different comfort level with that. But I don't believe that you should say that stage of the disease is the driver of that. So to say, oh, it's because you have stage 4 disease or you have stage 4 disease in the peritoneum, all of a sudden that eliminates that as a variable. I think most of the neuroendocrine specific programs would not agree with that statement.
Got it. Thank you very much. Speaking of surgery, I have another question. I haven't heard this one before. Debbie says, why are lung nets with mets above the collarbone not surgically done?
Well, I wouldn't have necessarily said that nets that are above the collarbone wouldn't be done. So,
okay.
So there's nothing actually unique to lung nets that wouldn't have the same principles be applied.
Okay.
And so that would probably be a very case specific answer. So if you're saying that a pulmonary net that is in the primary in the lung, well, the location of that is sort of irrelevant to the question. If they can get it out with a margin negative, they will.
Okay.
And so that would not preclude surgery. And if she means that if the lymph node basins above the collarbone, meaning that spread from the chest basin up into the neck, if that's limited disease there, that also would not limit surgical resection if eliminating the disease burden is part of the equation, and would then stave off the need for additional treatment like PRRT earlier than we would have wanted. All it does is make us a little more suspicious that the risk of additional nodes within the supraclavicular, that's above the collarbone, supraclavicular or the net are going to be, the risk is going to be there in that case.
So I'm not sure if she was told this or not, but maybe an opportunity for a second opinion.
Absolutely.
As always, as I know that you're an advocate of. Okay, it looks like we have a patient of yours, Dr. Maluccio. Jennifer says, my question is, are you at higher risk for secondary cancer when you have neuroendocrine? For example, I've had numerous melanoma within the past year. Any connection there?
So I wouldn't have said with melanoma, but if I was channeling Eugene Woltering right now, he would say that there are, when you see a lot of neuroendocrine patients and then all of a sudden you see a lot of patients have another diagnosis, like renal cell cancer is one of his big things. He's like, there's got to be a connection. I don't know what that connection is. I don't think that we understand the mutational connection that would be between those. But I do agree with Gene Woltering that it can't just be because of our catchment area that we see so many neuroendocrine patients that have a coincident diagnosis in their lifetime of a renal cell cancer. But that when you talk about something like melanoma has very unique risk factors. And we wouldn't actually say that they are genetically motivated risk factors, other than everything is obviously a genetic mutation that ultimately makes it become cancer, but that they are the sun exposure and the type of skin, fair-skinned, individuals. And then obviously there's going to be some family component of melanoma. So I would have never put melanoma on my list of cancers that would be, you would be at higher risk, or we would survey you differently if you had this history of a neuroendocrine. And I probably feel the same way about something like lung cancer, where the environmental exposures to lung cancer are so well established that someone wouldn't be saying, oh my God, you've got neuroendocrine. Oh my gosh, let's change our surveillance for lung cancer. But I'm sure that there are going to be other probably connections, but because it's all rare, you're never going to have enough events to say, oh, I believe that your pancreatic cancer, your colon cancer risk was associated with this, because we just don't have those genetic connections.
Got it. Thank you. Pretty broad question from Lynn, but I'm interested in this. You may or may not have the answer. Currently, how many people, she's just curious, how many people are living with any kind of net in the USA? Do you have any ballpark figure on that?
That is a very difficult question, but it's difficult because if you think about new net diagnoses per year, I think that's 7 per 100,000, and we have 400 million people in this country. So then you say, gosh, that's a lot of people. But then you have people like with midgut primaries, even when they're metastatic, that live 15, 20, sometimes longer, even with appreciable net disease. So if you live a really long time and you have almost 200 per state new diagnoses coming in per year, new diagnoses of neuroendocrine, right. I would imagine that number is astoundingly higher than you would think because it's a rare diagnosis. So I think that if you start to tally up the new diagnoses plus the average life expectancy of those patients, it's going to be into the millions upon millions, probably up to, 10 million. There's just not enough people that succumb to the disease each year that would drive those numbers down. But that's a great question. And I thought that no one could stump me on a question, but that's a really good question, but I think it's probably higher than you would imagine.
Well, there's actually two questions. The next one is same question, but globally.
Oh my God. Yeah. Well, and when you think about certain parts of the world, let's just put certain parts of the world that have a less sophisticated system by which people can get care, is that you have, even in this country, we think that most of the fact, it started at 3, then 4, then 4.5, then 5, and now we're up to 7 per 100,000. Right. And that's because we had a better understanding of the symptoms that were related to neuroendocrine, for which we then found it. Because you have a lot of people that potentially have or had neuroendocrine, have diarrhea, flushing, whatever it is, and then ultimately live to die of something else, having never actually had the diagnosis made. And then you were to take that to other parts of the world where the medical system is not quite as well established or sophisticated. And I can tell you that there are probably more people that are never diagnosed with it globally than we would imagine, either. But at the same time, it still constitutes a rare event for which we also don't have a lot of subspecialists, even in the US. So then you take that globally, and you're going to have entire countries in South America and Africa and parts of China that you have no specialists whatsoever, even within a 1,000-mile radius. So it's a difficult problem.
Absolutely. Marcella says, do you usually treat high-grade tumors, Ki-67 in the 30s, with IV chemo?
So the answer to that is predominantly yes. So high grade and Ki-67 are not necessarily synonymous. So you could have a well-differentiated Ki-67 of 30%. We call that a grade 3 well-differentiated, where we may or may not initiate chemotherapy early on in the course. And we would use similar techniques that we would with the lower grade G1, G2 tumors. But that's where you get into, if you look at your pathology report and you get the difference of the Ki-67, which is the proliferation index, and then the mitoses per 100 per 10 high power fields, you sort of get into a thing where you get into grade 1, grade 2, grade 3, well differentiated, but then we get into intermediate grade, and then we get into, frankly, high grade, which are the more aggressive tumors with Ki-67 values that are greater than 50%. The answer to that question, in the truly high grade, pathologically high grade, poorly differentiated Ki-67 greater than 50%, that's an easy answer. It's yes. If you were to get into some of the murkier areas where the Ki-67 is maybe between 20 and 30, it has a more well-differentiated look to it under the microscope. The grade 3 well-differentiated is probably, no, I wouldn't even call it controversial. It's the one where in some patients, those tumors can behave considerably more like their grade 1, grade 2 counterparts, and some of them will behave more like an intermediate grade. And I think for those of us in neuroendocrine, that's probably the patient category we feel the least confident that we are neither undertreating or overtreating. But I usually tell almost everyone in that grade 3 well-diff category that they have a moderate to high likelihood of needing chemotherapy over the course of their lifetime, even if that's not what we do right up front.
Got it. Next question from Ursula. How long after gallium dotatate PET scan can I start on sandostatin injections?
Well, so if you were to just get a somatostatin receptor PET or a gallium 68 PET scan, that you could start on your somatostatin receptor inhibitor at any time. Those two are the only way that those two are even remotely linked is the fact that they're competing for the same parking space. So the drug, how I describe the drug to people, is that's like the car. It's trying to find the same target, the somatostatin receptor, and like a police officer putting a boot on your car, it's trying to cripple the cell, keep it from spewing out stuff that gives you symptoms, and mess with the mechanisms by which it's trying to divide. But it is a competitive agonist, meaning that if you were to then put the car in with the pizza delivery light, gallium 68 or copper, it's all looking for the same parking space. So in general, it would be preferable to get the PET scan when you're at your lowest level of circulating somatostatin receptor inhibitor, which is why we will usually schedule them prior to a dose. But that once those cars are bound, meaning that the scan is done, then you would be able to start the somatostatin receptor inhibitor therapy even that same day.
Got it. Interesting question from Tom, who says, I'm not sure if this can be asked, but that builds up the suspense. I was notified that carcinoid tumors were added to the Zantac civil suit. I don't know nothing about this. What are your feelings about this being a potential cause?
Okay, so I think the disclaimer is that I don't know anything about the.
Okay, that's what I was gonna say. First question is like, any knowledge on that?
Exactly. So PPIs. So let's just talk about the Nexiums. That's not Zantac. Zantac is a histamine blocker. So PPIs, if you were to read the little pamphlet that we never read when we get a prescription from the pharmacy, in that pamphlet is going to be the risk of developing neuroendocrine tumors. They're usually within your stomach or duodenum. Now, in that context, they are usually non-invasive, unlikely to spread, and therefore unlikely to be significant drivers of mortality. And we have patients that still are on PPIs because gastroesophageal reflux complications can kill you too. So, but then the easiest thing to do is just take someone off of the proton pump inhibitors. Those are the omeprazoles, pantoprazoles, Nexiums, and things like that. So in general, we would usually actually put those patients onto H2 blockers, which are not quite as effective at treating gastroesophageal reflux disease or hyperacid states. So it's a little bit awkward to then say that the very strategy that we would use to treat someone's gastroesophageal reflux disease would be associated with the same problems that PPIs do. Now, it could be that data came out that it was, but that you have to look at it in the context of the comorbid conditions for which you are on those medications. And so I'd be hard pressed to say that I'd put my money down on that being a significant thing, but no, I don't really know anything. I don't even really understand the class action suit that pulled Zantac off the market in general.
Got it. Well, I'm not sure if that helps, Tom, but thanks for your question. Interesting, and appreciate your answer, Dr. Maluccio. We have a question from Karen and someone else I saw soon after about the latest info on the reliability of the Ren Laboratories NET test. And we've talked about this a little. We've talked about this a lot over the past couple of years, but even lately, because now it's been out for a little while. So the conversations that were once had about it have continued to be had, and people are maybe having more knowledge on it. But do you have any knowledge on the reliability of it in terms of being able to help diagnose?
Yeah, so that's also a good. So I think that if you were to look at any biotech thing, so for example, they were just saying that you could potentially do a stool study and start to talk about the risk or the likelihood of having pancreatic cancer, and it gets so much buzz. Like you're just like, oh my God, wouldn't that be easy? We could just do the little Cologuard thing and it lines up on our doorstep, and then someone could tell me, like a crystal ball, everything that is going to happen. And so I think that although I don't want to necessarily negate some of the progress that's been made with a number of technologies that would help us in this avenue, is that I would always tell you that if you really start to crunch the numbers, the value is usually in far less numbers of actual people that it would be pertinent to. But once again, I don't want to dog the technology because it's really evolving super rapidly, and that it would revolutionize the way that we would manage a bunch of different cancer subtypes. But that I think that for neuroendocrine, that is a heterogeneous group. It's really like 10 different diagnoses. Definitely. To think that there's going to be anything that's going to come up and say, oh my gosh, this is going to change the face of how we manage neuroendocrine. I don't want to sound like a skeptic, but I'm a skeptic.
Fair, totally fair. And for Karen, and it was actually Allison who asked a similar question. I just want to say, as I always do, we had Dr. Maudlin on the very first episode of Lunch with the Experts back in July of 2020. And so that's the source I would go to. We talked all about it. I know it's been under discussion from a lot of people who don't necessarily have a lot of experience with it. So it's currently discussed quite a bit, but that's a good place for you to start. That hopefully will help. As I stated in the beginning of the program, there's pretty much a video for almost everything in this realm that we've helped create for CCF. So
if I were to add on to that,
please.
Not just about CCF, but there are other videos. There have been panel discussions that have included geneticists that could probably be valuable to people that were asking some of the genetic questions, because geneticists, when you look through the lens of someone that truly understands genetics, mutations, acquired mutations, environmental exposures, is that I think I learned something on that panel discussion with the geneticist. I think that was probably something that came out from NANETS, the neuroendocrine, or the North American Neuroendocrine Program site. I bet those are also going to be online, just like yours are. Yep. There's so much information out there, and those are really nuanced to people that live and breathe those types of techniques.
Absolutely. Great point. Thank you for adding that. Folks, we got about just a little more than 10 minutes left, and we are going to take advantage of that, especially with Dr. Maluccio being here and having such great, thorough answers to these questions. From Jeffrey, okay, a little context, well-differentiated KI67 is 44.6%, and I'm moving to everolimus. What can be added to everolimus to help to improve long-term response? And he also says FGFR1 amplification as well.
Okay, so that's also a sort of a very patient-specific question. So combination therapies. So when we talk about single agents versus combination agents, is that anything that you would be combining with everolimus in terms of systemic, like whether or not it be immune modulation or whatever. So everolimus or Afinitor is an mTOR inhibitor. So it's trying to attack one mechanism, but that anything in combination would be experimental. So that would, in order to understand what people are potentially combining with that systemically, would be found on different chemotherapy style institution, national or international clinical trials. And I think that once again, some of these organizations will populate their website with some of the clinical trials that are coming down the pike. There's going to be nothing established that you could combine with Afinitor that's going to improve something. Now, when you are talking about the other standard strategies, be that liver-directed therapies or surgical therapies or things like that, is that once again, those are also not well-established treatment clinical pathways. So even though the University of Kentucky actually published or presented some very interesting data looking at liver metastases and the use of embolization techniques in patients that are on Afinitor, I thought that their data was quite thought-provoking, to the point where I was just like, well, maybe is that what's something that could help us at least control better the disease in that site? But that if the question is about combination systemic therapies, that would be in the area of a clinical trial.
Got it. Thank you very much. From Ajid, I think that's how I'm pronouncing your name correctly this time. I saw you for the first time last week. Let me know if I've messed it up again. I had a bowel resection in 2011, which removed the well-differentiated neuroendocrine tumor in the primary. I had a scan every year, which didn't show any reoccurrence until 2019, so 8 years later. And then in 2019, the scan indicated a 4-centimeter tumor by the duodenum, with other metastases in the mesentery and the clavicular fossa. Review of the previous scan didn't show anything. Okay, so the question is, how can a slow-growing tumor reach 4 centimeters in 1 year?
Okay, yeah, so that's actually a great question. And although I wouldn't say that scenario is common.
Okay.
So we talk about midgut neuroendocrine tumors as being very indolent and slow growing. And you have a surprising number of people that will get late recurrences. But 8 years is pretty outside this, even though within our own program, I've seen it at 10 years, I've seen it at 12 years. But the fact is the disease was always there. And it was just so slow growing and potentially kept in check by your own mechanisms of defense that either your mechanisms of defense changed as you aged, or those cells over time developed the ability to divide more rapidly. So the way that we would look at that scenario is that is merely a deeper lymph node basin. Lymph node basins are like a huge spider web that goes over your whole body. And when we're looking at them in the mesentery, we call them like first order mesentery, the ones closest to the intestine, then second order in the middle, then deep mesenteric. And what she may be describing is truly retroperitoneal, meaning it's heading towards the center, which is really the back of your body, but the center of where all of those lymph node basins are extending. And so that's merely the disease process and a late recurrence, not unheard of, not that common, but at the same time, it's water under the bridge because it happened.
Okay.
Now, a lot of times you will take that out, and for whatever reason, it looks like it's like an identical twin of the one that you had removed, which you would ask yourself the same question. You'd be like, yeah, but it grew to 4 centimeters. Sometimes it will be a sibling, meaning that it looks very much like it. The Ki-67 number is still maybe low, but maybe you have some grade migration, meaning it used to be a grade 1, but that now it's a grade 2, somewhere between a Ki-67 of 3 up to around 20%. Mm-hmm. Grade migration would be the most likely suspicion under these circumstances. That would say that nothing shows up, nothing shows up, nothing shows up. We keep you under a microscope every year, and yet something's able to grow from nothing to 4 centimeters. I would say that I'd put my money down on that being a higher grade, tumor. And yes, then that increases the risk of there being other cells that are of similar high grade, mm-hmm. but it wouldn't necessarily mean that all of the treatment options we would have used for the primary are not also available for that node, around your duodenum.
Got it. Thanks so much, folks. We got about 5 minutes. I'm going to try to get a few more for you. From Bess, can surgery be considered for cutaneous metastases to reduce tumor load?
Yeah. So let me just get the question right. You mean, would we ever cytoreduce subcutaneous metastases? Under the skin?
I don't know. Can surgery be considered for cutaneous metastases to reduce tumor load?
Yeah, rarely. So I would have said if there's somatostatin receptor avid, PRRT would be the better thing. So cutaneous metastases, that's something that is extraordinarily unusual.
Okay.
And I think the only time that we would take a surgical approach to that would be if they were symptomatic or in a particularly difficult area from a symptom standpoint. But then if you just think about the skin as being the largest organ in your body, is that the likelihood of being able to have that impact long-term survival is absolutely would be highly unlikely. And therefore a surgical approach would be associated with complications for no established benefit. So I would be doing it with palliative intent for things that are symptomatic or in an awkward location, rather than doing it like we would usually use the word cytoreduction.
Got it. And a follow-up question: do they grow at the same rate as other locations?
Well, I've only had probably a handful of people with cutaneous manifestations at all, and I would say that, if anything, I would say that they were a more difficult problem than other locations, as if there's something about that site that somehow allows them to be multifocal. But that I want to say, in most of the cases where I've seen it and we biopsied it to make the diagnosis, it wasn't because they were particularly aggressive from a grade standpoint, but that it is a particularly daunting problem. So that would be something where a patient-specific thing, that's when I would be taking that to the neuroendocrine, we all get along as a neuroendocrine community, and say, what would we tell a patient with this particular problem? Because I don't think any of us have ever seen it happen, enough times to say, oh my gosh, we totally have a consensus on that. But I want to reiterate in these programs is that neuroendocrine programs, it's a pretty small family. We all get along extraordinarily well. We are in no ways competitive. We are very collaborative. And these are the types of things that I would be like making a shout out to my friends at other neuroendocrine centers and say, hey, what advice would you give to this person?
Got it. Lovely. Thank you. Back to PRRT. Amy says, question on PRRT and octreotide. Both are using the same receptor on the cell, correct? Yes. Then will they compete for receptor sites if octreotide is used 4 hours after PRRT infusion? Okay.
So that's actually part of the protocol and how it was studied. So yes, they are a competitive agonist, and yes, they are targeting the same cells. The slightly different thing is that one is binding irreversible to the receptor and being internalized by the cell, and the other circulating, meaning if I go back to my boot on the car, analogy, the boot is on the car, the boot is off the car, the boot is on the car, the boot is off the car, because those cars are constantly coming off and back on a receptor. That's why, if you think about it, why someone can actually have certain tumor cells grow, even though they are on this very good suppressive medication. So if I were to understand the rationale, because these aren't spelled out in black and white, the idea is that you take someone off of the drug, the injection drug, 28 days before PRRT in order to open up those receptors. And then you give the PRRT, and it's going to bind to a fixed number of receptors, because once again, it's not circulating all the time. It circulates for a certain amount of time, but it's going to bind to a certain number of receptors. And therefore, the dose that you're giving after PRRT is trying to saturate the remainder of the open ones, not the ones that are already bound, but the open ones, in order to ultimately augment a suppressive effect. So it sounds counterintuitive, but I want to reassure people that is how it was studied, and that is part of the protocol, so that it in no way eliminates or diminishes the effectiveness of PRRT.
Got it. Awesome. Well, folks, that is our hour right on the dot. If you are as appreciative as I am for our guest today, say thanks, Dr. Maluccio, in the comments. Dr. Maluccio, I can't thank you enough for being here, especially last minute. Very, very helpful, and we're happy to have you back. And you explain things in such a beautiful way. I really love having you on the show.
Great. No, I really appreciate even having the opportunity to come back on. And I promise everyone that they will ultimately get Phil Boudreau on the show.
Absolutely. And thanks to Dr. Boudreau, and good luck where you are. Thanks to you as well at home for joining us. As always, we hope this program helped answer some of your questions. And again, I'll reiterate, reach out to ccf@carcinoid.org, or here on the Facebook page. You can direct message them for further information if you have any other follow-up questions. Thanks again to our presenting sponsor, Ipsen Biopharmaceuticals. We could not do this show without them. And finally, my name is Rain Bennett. I have been your host. Thank you for watching. And please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everybody. Bye-bye.